Hey, Dr. C here with you. So which thyroid test do you need to get? This is a question that we get a lot, and there's been a lot of things written about that. And it seems like the longest answers become the most popular, like the longest, most exhaustive list of tests. But that's not how things work. More is not better in this case. It can often be misleading. So I first want to make a big distinction between, what is the purpose of testing? Are you testing because you don't know why you have symptoms and you're wondering if you have thyroid disease or not? That's one thing. Is this part of your routine annual checkup? That's another thing. Or have you just have your dose adjusted? Are you just trying to see if you're at the right level or not? That's a third scenario. I'll talk about all of these. So first off, we think about those who are possibly being diagnosed. Their weight's been a struggle, they're not feeling well, and they don't know what's causing it. And they've come to suspect their thyroid might be an issue. Their doctor's going to test them for that, and they know that if the doctor misses important tests, the thyroid disease may not show up even if it is there. So the most typical thing a doctor would do in a case like that is only test the TSH. And if someone has severe thyroid disease, it can show up, it can be useful. But if someone's not at that worst stage, it may not show up. So we now know that there's a big gulf between having normal TSH levels and having healthy TSH levels. You can be at a point to where you're not feeling your best, your thyroid is clearly off in some way, but your TSH has not yet gone high. Now, the TSH, thyroid stimulating hormone, it's a backward test. So the higher it is, the less active your thyroid is, and vice versa. So as your thyroid slows down, the TSH gets higher. And with ranges, we think about 0.4 to 4.5 as the typical normal range in laboratories. But when you're on the higher side of that, that's often significant. So somewhere above 1.9, 2.0, 2.5, the more consistently you are in that high range, and the more you're elevating, the more likely it is your thyroid is contributing to your symptoms. Now, healthy people may occasionally have a reading of 2, 3, high 3s, and then bounce back down again. And that's not always significant. But if you're consistently up and you're consistently not well in ways that lack other explanations, this can be important. Now, there are times too to where the TSH may be perfectly optimal, but the autoimmune portion of the disease is causing your symptoms. And those are cases where checking the antibodies is helpful. So for screening someone to explain their symptoms, it's important to check the TSH and also the thyroid antibodies. That includes the thyroid peroxidase, or TPO, and antithyroglobulin, or TG. Now, there's thyroglobulin and antithyroglobulin. So we'll come back to thyroglobulin, but they're different. So just know that they are distinct. When someone's being screened to explain symptoms, it can also be helpful to check their free T4 and free T3 levels. There aren't a lot of cases in which they give data that one would not have by seeing the TSH. And that's because they are the later things to change in the process. So there's a sequence. If you've got too much or too little thyroid hormone, the TSH is the first thing to move. The free hormones are the last thing to clearly show that, because your body works really hard to keep them at a good amount, even if your thyroid is not making the right amount. So yeah, they're not the first thing to show a problem, they're the last thing to show the problem. So the main blowback against the conventional world is that they only check the TSH and they only look at the range, and in many cases they're not even concerned unless it's way out of range. And that's not good, that misses quite a bit. So the better approach is to definitely look at it and put weight on it, but know that it's more important to have it optimal than just normal. So that's the biggest factor if someone's trying to explain symptoms. Now, if someone's known to have thyroid disease, we also then want to think about the structure of their thyroid. And that's where ultrasound tests come in. Those are ones that are going to help know if the gland is enlarging, if we have nodules, if there's a goiter present, if there's precancerous signs or suspicious cancerous signs. So that's helpful when someone is known to have thyroid disease. And something that, per the findings on the ultrasound, good to repeat annually with a checkup, or perhaps more or less frequently if the doctor suggests that. If it's completely clear, nothing's worrisome, annual would not be necessary. And if there are unusual findings, it may take extra steps, such as a biopsy, further evaluation, or it may take a repeat ultrasound at a shorter time frame to see what the trend of growth is. So that's the other critical thing. So now, what about for those who are on treatment and they just had their dose adjusted? What do they need to test? Honestly, you can do pretty well on just a TSH. You can just measure a TSH in that case. And the advantage of doing so is that it's just less tests, fewer tests to pay for. If insurance covers it, that's great. But even if with coverage, if too many tests are ordered too often, they may start denying coverage. They may start not covering all that. And then many people are paying for their own tests. So that can be helpful and it can be just as useful. Now, if you do change a dose and you don't have your T3 and T4 present, you still see the trend of whether or not there's more or less there. And there are those that put a lot of thought into the proportions of T3 and T4. That's coming up if someone is taking separate T3 and T4. In some cases, you may want to know how those are working individually. But even then, the difficulty is you don't see what they do until they're at the extremes. Someone can take T3 and take more of it. That doesn't mean their T3 will go up proportionally. In many cases, the opposite can happen. But the first thing to change will be the TSH. So what I've come to do over quarter century of this is to think about the proportions of thyroid hormone. And in our circulation, our body has a ratio of about 3.5 parts of T4 to every 1 part of T3. Now, you'll hear different numbers, but they're based upon what's released from the gland or what's inside the gland. But that's all before conversion and activation. And many struggle with conversion and activation. So once the body has converted them, and you just look at what's there active in the circulation, the ratio is about 3.5 to 1. And that's pretty consistent with natural desiccated thyroid. If someone's on synthetic thyroid, T3 and T4, I don't use those same ratios. I'll use a lot less T3, like probably a 10 to 1 ratio or even a 20 to 1 ratio. But in natural desiccated thyroid, the ratios are good. And in those cases, I don't think as much about micromanaging T3 and T4. First off is getting the TSH correct. So for dose adjustments, one can do really well by just looking at a TSH. So those aren't all the thyroid tests. So what about others? What about the ones you don't need? Well, big one is reverse T3. I don't test it, and I discourage people from doing so. If it's high, we don't know if that's significant. Many healthy people have high reverse T3, and it's not of any consequence. When reverse T3 is high, really high, it's almost always from someone just taking too much thyroid medication. And we already see that because their TSH is low. So it's not data that you wouldn't have otherwise. People only have high reverse T3 for just no reason or because their body is doing it on purpose. There really aren't situations in which the body, by some mistake, makes reverse T3. It's the normal thing we make T4 into. It's the normal byproduct. And we need some. Our brain depends upon reverse T3. So it's not a bad thing. But it's not something that we need to micromanage, and it's something that can only just cause a lot of confusion. And because we don't really know its significance clinically, I don't encourage testing for that. I've written a lot more detail about that, so I'll not go into that at this point. Total T4, total T3. Total T4, it doesn't give different data than free T4, but it's a little bit less precise. So the hormones can be in an active free state or in a bound up inactive state. So total T4, or if it just says T4 and not free T4, that's both the active plus the inactive fraction. And so it doesn't yield new data. Total T3, there might be some cases in which that can be more useful than free T3. That's more so in managing hyperthyroidism, but normally total T3 is not needed. T3 reverse uptake. So this relates to thyroid binding globulin. And now that we have access to measure thyroid binding globulin if needed, but more importantly, we can measure free T4, it doesn't really help to measure free T3 uptake, not a necessary test any longer. We also have T7 or T4 index, free thyroxine index, and same thing, not necessary now that we have free T4 measurements. Those were past ways of trying to gauge free T4, but now we have just direct measurements of that. So that's the basic idea. I'm going to share some ideas about what optimal levels will look like, but those are the things to really test for your thyroid. If you're newly being diagnosed, TSH, the free T3 and T4, thyroid antibodies, anti-TPO and anti-thyroglobulin, and a thyroid ultrasound. If someone has had structural disease, sometimes thyroglobulin is helpful, not necessarily. And if you're adjusting your dose, you can measure TSH, T3, T4 in the free forms, but in almost all cases, the TSH alone can be adequate for looking at the effects of a dose adjustment. One last thing along that point, the TSH will take about 3 months to reach a steady state, so that's a drawback for using it for a dose adjustment. One can measure it prior to 3 months, but one must bear in mind that it's not yet leveled out. So in that context, you're thinking more about which direction has it moved and how much has it moved, not so much just the reading. So yeah, that's that. All right, Dr. C with you. Take great care, and I'll see you again real soon.